Time to talk family. Welcome. Here we are to another great show I have planned for you. I'm so super excited. First of all, let me thank my family here, knowledge and nonsense, and time to talk. Just hardly contain myself. We've heard it for the last couple of months. Everybody's had their challenges with it of how to become compliant. But ST91, it was a lot of back and forth about how do we get to where this new standard says take us. So there was a lot of confusion about what the new standard was and what we were going to do with the existing designs and how long do I have to become compliant. I'm here today to help you understand what that standard is, some of the changes that happen. I brought in an expert to help us get the understanding. When you're processing these flexible scopes and you're going through your daily processes, yes, the changes might have added times to your real times. You might have heard people say, oh, if it can be sterilized, let's sterilize it. And you're sitting there thinking to yourself, well, we've always did the high level disinfection. How can I accomplish this? We are not set up for this. And but today, hopefully, we can erase some of the confusion, add clarity to what they meant by that. And when they say, oh, my staff now needs to be certified, let's give them the answer to why that is. Let's put some answers to all of those questions that you may have been asking yourself for the last couple of months. ST91, it breaks down the what, the why, how. All of those nuances that come with the flexible, semi-rigid scopes and what needs to be done to ensure that we give that patient the best possible outcome every single time. But what I did, I went out and found somebody who not only can speak to I brought you none other than Mr. Adam Okada. He's going to be here today to talk to us about what changes, what happened, where, what, when, how. So let's give him a warm family welcome to the show today. Adam,
Thank you.
my man, what's going on, sir? How are you?
I'm doing good. How are you?
Hey, I'm great. This is one of my topics. I am so excited about it. Unlike some people who have not had the chance to hear you and the passion that you have for this, I actually got to hear you speak on it. And from the moment I heard you, I knew I needed to bring you here to talk to the family about this. I the questions. I've heard the whispers in the wind, and it's just enlightened to know somebody that was there. That's the
Yeah.
thing. There when the questions and you were there when the this happened, and now hearing it straight from somebody who was there maybe would give people that moment of clarity that they needed. ST91, what was the big fuss? Why?
Yeah. I
What?
mean,
When I
go ahead. Go ahead.
can you hear me? I'm sorry. Okay, so
Yeah, I can.
ST91, we know we heard there was changes, and when it rolled out, everybody was like in a like, oh my, what am I gonna do now? How can I accomplish this? There was no timelines given. There was nothing to say you had to be compliant tomorrow. You had a year, you had 2 years, but everybody looked at it now. So, from a standpoint of somebody being in the room that happened, in the room where it happened, what was the thought process behind the changes?
Yeah. I mean, the first of all, thank you for having me. I'm so excited to be here and talk to you guys about this. But yeah, ST91. When you join the AMI guidelines, because I joined probably about 4 or 5 years ago, and then going to my first meeting, I was nervous. I was with all of these industry experts that I had seen. You know, and like on webinars, I'd seen them on stage at HSPA. I've seen all these people, all over the place. And being in the room where we were actually writing the standards was just incredibly, incredibly exciting. And what I learned is they really want input from the field. So when we talked about ST91 and kind of adjusting the standards and kind of bringing us up to date, it was a lot of trying to figure out what's happening in the field, what's actually happening in departments right now, and then what are the adverse outcomes that are occurring? What are the infections? Where are they coming from? Is it machines? Is it the scopes? Is it the water quality? Where are these things coming from? And then giving suggestions to kind of put patches on some of the gaps that we have in processing. We know that there are problems with doctors that want to schedule too many cases. They want their scopes right now. They don't care if it's been cleaned properly. And they have a lot of time pressures. And so we know that going in. So there are a lot of stop gaps in the recommendations that say, look, you have to do certain steps, the drying steps, the cleaning verification. I know we're going to get into all these things today, which I'm super excited about. But it was really based on the things that we see in the field, and especially around the FDA mod database, which is the database where they're reporting adverse outcomes. That's the percentage of things we see in the news. Like when a hospital gets to the news, they're getting shut down, they're having problems, they have an outbreak, whatever it is. That is a tiny fraction of what's actually happening. The actual infections, the actual problems that they have with scopes. And so that was the kind of data that we pulled from. We pulled from a lot of studies. Ofsted and Associates has done a number of studies on endoscopes. We used that and cited those in the ST91. But it's really based on the real world outcomes that we're seeing in the field.
Now, just on that part where you talked about that, so just if I were just flipping through the changes and the standards and how they recommend all of these things, and yes, going from your normal processing to these extended things, it does add a little bit of time. Was that taken into consideration? Like per scope, it added this added time, even though it added value to what you were doing, it added time. Was that taken into consideration that it would be, I mean, take away from the number of cases that possibly could be in, or that facilities would have to add to the inventory possibly?
Yeah, and I mean that was a lot of the user feedback on all of these things that we tried to implement was, look, the real world situation is we're going to have a hard time complying with certain parts of the standard, and that was definitely something we kind of talked about. Okay, well, we know that the infection rates are high. We know that that's not good. We need to do something in the standards to try to help us move forward and move towards patient safety. And we also need to take into consideration the real world applications. Some of these places are in one room reprocessing areas. We recommend two, but some of them are in one room. And we know that there's places that just can't physically put in all the things that are in the standard. But again, it was more about realizing what's actually happening, and then where is the most important places where we can put in quality monitors, cleaning verification, and things like that, where those things should hopefully help patient safety going forward. So it's always that kind of push-pull. Patient safety on one side, we know that's important. How much time can we realistically put in to ensure patient safety and also ensure that the scopes are going to be ready on time? So it was a back and forth, and it's always going to be, considering both sides of that.
Right. And I saw some of the language and some of the actual standards. I actually got my own copy and I read it extensively. And you see certain things that say recommended. You see should. You see the shall. And people were like, well, which one do I have to drop dead do right now versus, okay, I can get to that later. How do you decipher what is a must have versus, okay, they just recommended it. As I said, I have to try.
Yeah, I think that the first, the most important word is must. So when you're reading through the standard, and I recommend everybody actually go and get a copy of ST91. Okay. If your hospital doesn't pay for it, I would strongly suggest that you make the case for them to get ST91, because if you're doing flexible scopes, it's invaluable to what you're doing. But must is the strongest language that the standards can use, and must is usually a regulatory requirement or something that's unavoidable, like an OSHA PPE requirement, for example. So PPE would be a must in the statement because it's a law, it's a regulatory requirement. As far as the AAMI document goes,
Right.
the strongest language that AAMI can use is shall. So shall is next to
Okay.
must, and shall is essentially if you have the capability. Well, not even if you have the capability. Shall is really the strongest language to say you need to be doing this thing, and the standards are telling you to do it. Below that is should. So should is if you have the capability and you have the resources to do it. This is something you should be doing. Below that, you're going to see words like may, can. Can is just a statement of capability. And so like may is like if you have this process that you're doing and it's in the standard as a may, it's permissible to do that. But as you're reading through it, I think that the key things, the key takeaways, because there's so many changes. There's literally like dozens of changes to how many standards there are. The thing you really want to look for is the musts and the shalls first. And then once you get those nailed down, then you move on to like shoulds. So if you're reading through the standard, that's a really helpful way to look at the document. Must and shall are first, and then should would be next.
Now, in your working with the ST91 and working with different facilities, how have you seen people strongly make their case to obtain a copy ST91 if they don't have it as far as their facility having it or the departments having it? I've seen different ways that people make the case to get a copy of it.
So I actually was able to get a copy of ST91 in a facility that I was working at. We were currently not doing, or when I got there, they were not doing flexible scopes, and the idea was that SPD would start to take those over little by little. So I had to go to the C-suite and essentially say, look, the hospital needs a copy of ST91. We were able to get it for our health system. I was in charge of 3 hospitals. So we were able to get that copy for all 3 hospitals. But I think you do it because you're wanting to comply with standards. And the ST91 is literally kind of the newest one that's out there. And it's really moving the industry in a direction where it's going to be in the future. We really feel like sterilization of flexible scopes is going to be the future of the industry. Spalding is great for what it is, the non-critical or critical, semi-critical, non-critical items and things like that. But when we talk about high-level disinfection and just stopping flexible scopes at that level, maybe that's where we kind of rethink Spalding and say, flexible scopes, we see so many outbreaks, maybe high-level disinfection just isn't enough. Let's move towards sterilization. And that would be my argument to going to the C-suite is, look, this is going to be the future. We need to get in front of where we're going. Otherwise, we're just going to be playing catch up. And the standard, when regulatory comes around, surveys come, you're just going to be playing catch up with them every time. So it's better to get the standard, get in front, take care of those musts and shalls first, then move on to shoulds and may.
It's to taking the forward thinking to the C-suite to try to make the argument for what you're going to be doing in future tense. That's the best possible route to get the C-suite on board or to be doing anyway.
Yeah. And I mean, honestly, telling them that, you need it for regulatory surveys, they're usually pretty okay with that because they want to pass surveys. They want that accreditation. And they don't want them coming back every couple of weeks to recheck. So, yeah, definitely something to tell C-suite is regulatory.
Okay. Well, just in doing my research, I think I'm going to jump right in. I saw some change. Let me start with one of the most obvious ones. So before, with everything they used to do, they say, hey, before a scope had to be brought to us, it had to be pre-cleaned at bedside. There was pre-cleaning that was done by the staff in the room. Now I see that language has gone to pre-treatment. What was the significance in pre-treatment versus pre-cleaning?
Yeah, so pre-cleaning is a very specific thing talking about the cleaning of the scope at the bedside, but there's a lot more that happens at the point of use. So the new terminology is point of use treatment to describe everything that's done at the point of use. So that includes the accessories, wiping things down, flushing, protecting the scope for transportation is a huge part. So again, in the real world studies that were shown, they were showing a lot of, they wipe the scope down and then they just toss it in a bin and then the bin gets carried down to SPD. Well, is the bin an approved bin? Does it have puncture proof sides? Does it have a lid? Like all of these things. So Point of use treatment is now a much broader term. So it's everything done at the point of use, and there's multiple steps involved in point of use treatment. So pre-cleaning is part of it, but it's a much, and it's kind of like I equate it to like IUSS, immediate use steam sterilization. That's a much better
Right.
terminology instead of flash. Flash was just, oh, it's going to be ready really quickly. Immediate use means you have to use it immediately, and so that terminology helps to encompass what we're actually talking about. At least for me, it makes it a little more clear.
So when they say point of use treatment, that encompasses the transport of it, saying you have the appropriate container to transport it in, that you separated any kind of accessories from the scope. So that part and puts it in its own category.
Correct. Yeah, everything done at the point of use, including getting the scope ready for transportation. So it puts a lot more of the onus on the actual endoscopy or whoever's doing the flexible scope case to understand that there's a lot more to it than just wiping the scope down or flushing it.
Now, okay, so I get that we get, and I say this lightly, I know that we're tested on the fact that we know what happens at that point. But for somebody that's in the treatment, the decontamination area, waiting on a scope to come, just by them looking at the scope coming, how are they supposed to know that that's being done?
That's part of point of use treatment too. Is there is some communication that needs to happen from the point of use to the decontamination area. You need to know patient information, the time the scope was pre-cleaned, and all of those things are important for processing because, and this is another part of the standard that we can get into, is the delayed processing. Delayed processing of scopes is another huge issue. Olympus has IFUs around delayed processing, a lot of scope manufacturers, and it actually is part of the standard too, where the delayed processing protocols get brought in. But that's part of it, the labeling from the OR or the point of use as well.
Okay, so just in that language changing, it does encompass more than just the pre-cleaning. It does encompass the transport to what happens during, and it takes that part out of it just to say we're not just cleaning it, but we're telling you what's supposed to happen. If this doesn't happen, this is supposed to happen. And of course, if it is a delayed, we will follow the manufacturer's instructions on what reprocessing looks like. Okay. So
Exactly.
I mean, that was a big question. Like, why did we go away from the cleaning to treatment? What does that mean? People were asking different questions about that. So that up really good. I like that a lot. So in saying that, transported it down. Another thing that came up was the workflow design. We talked about when they bring it in the area, it is recommended that they have multiple sinks for them to process in. Now, again, people budgets may not allow this immediately. But what does that mean if I only have the one sink, which I've had for years? I've had one sink to process in. I've done all my leak testing, my washing, my rinsing in one sink, and now you're telling me that's not appropriate. What happened?
Yeah. And that's something that I think when people read the standard, they get a little freaked out, especially if they're in little clinics where you've got one room processing. Believe me, I have been in those places where you've got one room, one sink to do the flexible scope. So in the recommendation, it's recommended to do 2 sinks, at least 2, ideally 3 sink system for flexible scopes. Or if you have one sink, you would separate the sink so you've got cleaning on one side and then a clean rinsing sink in the other side. And the reason for that is just because cross-contamination. If you're doing the scope, the dirty scope in the sink, and then you're rinsing in the clean sink at the same place, there's an obvious cross-contamination risk. And so based on things that they'd seen in one-room designs or one sink designs, the recommendation was made to move to that. It's not so much, I think, for existing places. Yes, the languages should in a lot of those places, or in this part of the document. And it's really about if you're going to be moving or going to a new area or you get a different space where you can build your own endoscopy, these are the recommendations you would want to follow. So If you're stuck in the one room design, totally understandable. We understand how that works. Try to get the separation in that one sink so you have a clean and a dirty side. And if you're not able to comply with 3 sinks right away, it's really more about the future state, where someday if you move into a place where you can do that, these are what the recommendations are saying. But the workflow, we know, has to go from clean to dirty. As soon as you're going back and forth in your dirty PPE to go to a clean area and do something in that area, you're going to be cross-contaminating. So the one-way workflow, all those things are designed to prevent those cross-contaminations from happening.
Okay, so I'm a big advocate here. If I have the one sink, or I'm not able to, upgrade, or even if I'm preparing my budget and I'm saying, okay, well, I'm washing it, rinsing it, and this is just water. I've cleaned it and I'm rinsing it off. Why would I need a second sink for that if I'm just rinsing the water off and it's going down the sink? How could I cross contaminate with water?
If it's in the same sink, I mean, you can imagine there's a lot of splash, there's a lot of contamination in that sink, and not just on the sink, all the area kind of around it. One of the most recent splash studies that Austin Associates did with Marie Brewer's Hospital, I believe, is that they did a splash study and droplets were going as far as 6 to 10 feet back behind the SPD technician, which says to me that there is a lot of splashing and a lot of aerosolization of contamination. And so if you're in the exact same sink where you're doing manual cleaning, where the blood and the body fluids are coming out, you can spray that down and you can hopefully disinfect. We'll get into disinfection and wet contact time, because that's another one of my little pet peeves in the industry is wet contact time. But it's really about the risk of cross-contamination if you're in that sink. Now, if you're doing proper cleaning and proper disinfection, you do those surfaces between each one, then you're probably going to be okay. But the chances of cross-contamination are much higher if you're in that one sink. And so that's why we recommend at least 2.
Okay. Okay, yeah, it was a question that came up, and I was like, you know what? I would definitely ask because, yes, if it's just water going down the sink and I'm rinsing and it's still going down the same sink, how can I? But I saw that study, and yes, you're right. The droplets traveling 3 to 6 feet just from you cleaning. I guess people don't realize how 3 feet is not, and they showed how from her gown contaminated just from cleaning right there. So that was an eye opener for me just to show people that. So yeah, I get the whole now the 2 sinks, 3 sinks, and just to start the sink area does make a lot of sense to me. So on that same in that same realm there, leak testing. So we're leak testing at the sink there, and interestingly enough, you said that the leak tester needed verification.
Yeah.
How do we verify the leak test? So I got to leak test the leak tester. So I need to verify that my leak test. So
It's you cut out a little bit, Kenneth. Sorry.
testing a leak tester.
Yeah, and that was the way I was shown. Like when we would do flexible scopes and we were doing the leak tester, I was shown that you would take your gloved finger and you would put it on the leak tester, and if you heard the psst and it stopped, then it was good. You had air coming out. That was how you tested your leak tester.
Right.
Unfortunately, what we found out was if you look at the IFUs of a lot of these scopes, they have a leak tester pressure that they're required to have in order to properly test the scope. It makes sense that if you're leak testing it, you want to have a certain amount of pressure that's going through. So, and Sharon Rojo was, I believe, and I don't want to like quote it, but I believe he was the inventor of the leak tester tester. It was his idea because he saw that these pressures were really low. Sometimes the air was really light coming out of some of these leak testers. And when you would hook it up to a pressure gauge, you would see that the gauge was not high enough according to the IFU. So that was where we realized there could be leaks and people don't even realize it. So some of these older machines, the newer machines are great because a lot of them have pressure sensors inside of them. They'll actually tell you what the pressure is coming out. Those are awesome because you don't need to test that because it's actually pressurizing and telling you what it is on the machine. But for the older machines, the standalone units that were like kind of metal and beige, I had one of those when I started. So it's a very old machine. But when you hook those up, there is a leak tester available so that you can actually test your leak tester, make sure the correct pressures are coming out. And that way you know that your leak testing is actually effective. If it's not effective, that's, again, where we can see issues. If there's leaks, that's also a place where bioburden can get in and settle. So we definitely want to know that our scopes are being leak tested appropriately.
Okay, we're going to come right back to that. Let me take a quick commercial, and then we're going to come back and talk about what happens after you test the leak tester. We're going to come back right to that. Let's take a quick commercial. Be right back. Hey, welcome back. Welcome back. Right before the break, we were definitely talking about testing your leak tester. As we said, old school, we were definitely just putting our finger there, listening for the sound, making sure that it worked. Now they make devices that allow you to actually get the pressure reading. Now, Adam, with getting that pressure reading, what do we do with that information?
We just can verify what the pressure is with the IFU. And then just like the rest of the documentation, that should be documented. So when you test the leak tester, make sure it's working properly, you document what pressure is coming out.
Okay, and we just keep a record of it, just so just any kind of regulatory, we can show it if somebody asks that we're keeping track of that.
Yeah.
Okay.
Just like we document the leak testing itself, the pressure is also something that should be documented as well.
Okay. Now, another big one that came up was cleaning verifications. Making sure that after I've cleaned it, that is actually clean. So, what different type verifications, people use different methods, but the something that changed in it is that we don't have to do all the scopes all the time, but the high risk scopes every time, and we're documenting that we do the high risk scopes every time, and then now the possible use of a board behind that.
Yeah. So with the cleaning verification, the recommendations state that you should be doing some type of cleaning verification for high-risk endoscopes. High-risk endoscopes are any kind of elevator scopes that have that little elevator mechanism at the end. Bronchoscopes, ureteroscopes, cystoscopes, and EBUS, the ultrasound, the endobronchial ultrasound scope, so the EBUS. All of those are considered high-risk endoscopes. And the reason that they're high risk is because we've seen outbreaks. So the reason that list was chosen was because the majority of the outbreaks or infections were coming from these more complex scopes. So the more complex the scope is, or more complex the design, the more likely it is that infections can come. And so cleaning verification is one way. If it's being cleaned properly, then we know that the chances of having an infection on the opposite end are very low. So that's why there's a cleaning verification step for high-risk endoscopes specifically every single time. And then there is a recommendation also for the hospitals to do a risk assessment on the rest of their scopes to determine how often they need to do cleaning verification. But just wanting hospitals to really get into the habit of cleaning verification testing on your scopes to make sure they're getting cleaned properly at the sink. That is the number one step where we see things missed.
Now, in saying that, so the cleaning verification, whether that be, I know some people say the Resi test, and some people do, other things. So the borescope is in addition to, or can the borescope act as that cleaning verification?
Yeah, so the borescope is not replacing cleaning verification. It's one of the tools that you can use, and the language in the document, I believe, is you have the ability to use the borescope. It's definitely a tool at your disposal that can help determine things. And I know for me, well, it was very eye-opening the first time I saw a borescope. They came in and they were doing a demo, and they looked down one of our scopes, and it had been failing cleaning verification testing. We had no idea why. But when we looked down the scope, there were little scratches, and then probably from an instrument that had gone in and scratched the inside of the scope, there were these little scratches with little brown marks in them, and that's bioburden probably. So that was the reason we were
Right.
failing our testing, and that borescope helped to identify what the problem was. So the borescope is really a tool at your disposal for instrument inspection, really to verify things are good inside. And it's not something required. A lot of people are like, oh man, I got to go out and buy borescopes and all these things. It's not a requirement. It's not a
Right.
shall.
Right.
It's one of those things, though, that if you have it, you realize how valuable it is because you can see in places we've never been able to see before.
Now, again, just so to clarify, the borescope doesn't replace the cleaning verification. It's an additional tool that can be used along with just to give you a secondary look down to make sure that what you're verifying is clean is clean.
Exactly. And the recommendation has always been for lighted magnification. That's always been the standard. That when you're doing that instrument inspection after cleaning, that you make sure you're inspecting and seeing what's there. And lighted magnification is great, but borescope is one step further where you can actually see inside. So it's not replacing it, definitely a tool at your disposal to help.
Okay. Okay. And while we on the dirty side, let me just tie all of it together. There was one other section, I think it was a newer section that was added, and it was about water quality. Can you explain what that section, why it was added, and how do we determine the water quality, dirty side versus clean side? What is the water quality, and how do we get there, and why that section was added to the standard?
Yeah. So the reason that it was added to the standard was because of outcomes that have happened. When scopes are hung, we sort of assume that when scopes were hung in a HEPA filtered cabinet, that there was some form of drying that was happening, right? We do flush with water, we then flush with alcohol, and then we flush with air with our syringes. And we assumed there would be no water left inside the scope at that point. But what we realized after doing testing, and you could see a lot of those from Ofsted did another great webinar on that one, talking about the water left inside of scopes. Anywhere where there's water in a damp and dark environment, and an endoscope channel is perfect for this, you're going to see microbial growth. So based on these studies and based on the things we'd seen, water and things left inside of scopes was one of the number one things that we realized was causing problems. And with the water quality, a lot of waterborne pathogens actually live inside the water supply. So that was another form of outbreaks that we had seen was waterborne pathogens causing problems with scopes. And even after HLD, water and flushing and things like that with infected water was then causing outbreaks of infections in patients. So it really became an issue of, okay, well, how can we figure out where the steps are to look for water quality? So again, you check IFUs for your AER machines, your endoscope IFUs to see what kind of water quality they recommend. And even in your AER, there's recommendations about testing the water that's being flushed through the channels because we assume it's good. We just assume the AER is perfect all the time and it always works the same. But if there's waterborne pathogens living in the water supply, not even